Breast cancer is the commonest cancer in women in New Zealand at the moment, but it is one of the least deadly because of the great work that the breast surgeons, the radiologists and the pathologists do, detecting and diagnosing this disease early and treating it with specific therapies that aim at turning off the cancer cells. In this video, we're going to think about some benign changes that happen in the breast, fibrocystic change and fibroadenoma, and then we're going to think about breast cancer, particularly the tumour types, its prognosis, and the markers that we do on it that help us direct therapy. As illustrated in these pictures to the right, fibrocystic change in the breast does what it advertises. There is fibrosis and there are cysts. So far, so good. There are some other changes we should note as well. Sometimes these cysts are lined by apocrine cells. What are apocrine cells doing in the breast? Well, normal breast cells can turn into apocrine cells, the type that are usually found in sweat glands. And this particularly happens in fibrocystic change. In the picture on the left, you can see right at the top there's some dark purple stuff in the gland, and this is a calcification. So, on mammography, we look for calcifications. We can see them in both benign and malignant conditions, and fibrocystic change is one of the places where we can see benign calcifications. Sometimes when we look at benign breast tissue, we see epithelial hyperplasia. Now, this is not a pre-malignant change. What this means is the epithelial cells are growing in a benign pattern. They're often disorganized and jumbled, but they don't have any worrying cytologic atypia. They are confined within the breast ducts, and we know this because we can see the myoepithelial cells surrounding the breast duct, and this tells us that this is not an invasive process. The commonest benign tumour in the breast is the fibroadenoma, colloquially known as a breast mouse. I know, that's really weird, but it's because when the breast is examined, it slips between the fingers and is highly mobile. They're often ovoid and about this big. They run away from your fingers, a bit like mice. It's a relatively common benign lesion. It has both epithelial and stromal components. We see it mostly in women who are in their 30s, maybe 40s. They can be multiple. When we look at the lesions macroscopically, like this picture to the right, notice that they're well circumscribed. So this is in contrast to cancer, which infiltrates. They're solid and sometimes lobulated and quite pale looking. They can be small to quite big, giant fibroadenomas. If we look down the microscope at fibroadenoma, we can see that it is both a stromal and epithelial lesion. The stroma is what we call hypocellular. It doesn't have many cells in it, and they're quite uniform with no mitotic activity. Sometimes the glands in the fibroadenoma can be rounded. We call those a pericanalicular pattern, and sometimes they can be compressed, like in the top picture here. We call those an intracanalicular pattern. We don't expect you to remember those names, but you may see them in pathology reports. The epithelial component can show the same abnormalities that can be present in the normal breast, like hyperplasia and atypia, but we don't normally consider fibroadenomas to be a pre-malignant change. women are often interested in their risk of developing breast cancer. And the table at the right helps us understand the things that increase a woman's risk of breast cancer. So things like fibrocystic change and mild epithelial hyperplasia have absolutely no effect on the risk of developing breast cancer. Women who have more complex and florid epithelial hyperplasia, papillomas and things called complex sclerosing lesions have about double the risk of developing breast cancer. Let's put this in perspective. Every 5 years of age, a woman doubles her risk of breast cancer. So if someone has a papilloma at age 40, they have the breast cancer risk of a 45-year-old. Moving up in risk, there are conditions called ADH, atypical ductal hyperplasia, and atypical lobular hyperplasia. These increase the risk of breast cancer significantly more, to 4 to 5 times the population base rate. That's because cells in these conditions have started to accumulate the mutations that will eventually lead to cancer. And then finally, if a woman is diagnosed with lobular carcinoma in situ or ductal carcinoma in situ, then her risk of malignancy moves up to about 1 in 3, 8 to 10 times the normal population risk. Thinking of this from an epidemiological rather than a histological point of view, the risk factors for breast cancer are mainly hormonal and genetic. The most obvious one is, of course, you need 2 X chromosomes to be really at risk of breast cancer. Only about 1% of breast cancers are seen in men, and many of those men have a germline BRCA mutation. So, breast cancer is a disease of increasing age. We don't see breast cancer much in 20-year-olds. The peak risk of breast cancer is in a woman's 70s and 80s. Many of the other factors are related to the length of high estrogen exposure. So, for example, women with early menarche, late menopause will have an increased length of estrogen exposure and have a relative but small increased risk of breast cancer. Similarly, pregnancy and breastfeeding after pregnancy can also decrease the risk of breast cancer. In this situation, it's because the pregnancy modifies and matures the epithelial cells within the breast. Let's think for a moment about hereditary breast cancer. About 12% of breast cancers will arise in the setting of a family that has a high risk of breast cancer. Only 5% of cancers overall will actually be able to be attributed to a specific mutation, and most commonly these are BRCA1 and BRCA2. Now these are tumour suppressor genes. They have a normal role in DNA repair and cell cycle control. So if they're mutated and these functions are taken away, you can see how mutations accumulate and cells replicate, and thus cancer occurs. Mutation in the BRCA genes also increases the risk of ovarian cancer. Mutation in BRCA1 confers a risk of about 60% during a woman's lifetime of getting ovarian cancer. BRCA2 is associated with a much smaller risk of ovarian cancer, but is associated with a risk of male cancer, prostate and breast cancer. We can do genetic testing in people who have hereditary breast cancer or a high risk of breast cancer. This is done through the genetic testing services and requires a referral. Sometimes we can suspect that a woman might have a BRCA1 associated cancer because they have a particular appearance down the microscope. They're what we call triple negative. They lack estrogen receptors, progesterone receptors, and don't make HER2. Some families have other genes that make them susceptible to breast cancer, in particular P53 and P10. Let's get back to thinking about actual tumours. Ductal carcinoma in situ, which we usually call DCIS. I'm not convinced that these guys on the right here actually have DCIS, despite the jerseys. Back to the subject. Most DCIS can be detected because the ducts that are lined by the atypical cells make necrotic material that calcifies. We can see it on the mammogram. It can form a mass-like lesion, but most often it's undetectable until a woman goes and has her breast screened. It is a clonal population of atypical cells that are confined still to the duct. So the myoepithelial cells that tell us that the duct is intact are still there. And it can spread through the ducts. It can travel down those long, tortuous breast ducts over quite a wide area in the breast. But it's not invasive. It won't metastasize. This is what it looks like down the microscope. A round, intact duct lined by markedly atypical, pleomorphic, mitotically active cells surrounding a central core of necrosis, which becomes calcified and we can detect just in time before it invades. Sometimes cancer within the ducts, DCIS, can spread through those ducts right up to the nipple. And then it can infest the epithelium of the nipple, forming these little groups of cells. We call this Paget's disease of the nipple. I'm sure you've heard about Paget's disease of the nipple. It looks red and resembles eczema. Now, most people who have irritated nipples do have eczema, but this is a red flag sign. So if a woman develops something that looks like eczema on the nipple, then we have to make sure it's not Paget's disease of the nipple. So to revise, in Paget's disease of the nipple, malignant cells extend from the DCIS to the skin via the large ducts. They don't cross the basement membrane, so there's no invasion. On to the real deal, infiltrating ductal carcinoma. So this makes up about 80% of all cancers in the breast. The commonest kind we call no special type or not otherwise specified, because there are some special types that we're going to talk about. This is a typical breast cancer. Macroscopically it's pale, irregular and hard. We call them serous because they're sclerosing. They feel like scoria. The breast cancer cells themselves aren't hard. It's the fibrosis that surrounds them that gives the characteristic hard, irregular feel. The other main type of breast cancer is invasive lobular carcinoma, and this makes up about 10% of breast cancers. It's a discohesive cancer. Discohesive because it has a mutation in the E-cadherin gene, and the cadherins are like the Velcro that hold cells together, so it loses its attachment. This is why this discohesive infiltrating tumour is often seen in single files or loose clusters or sheets. It doesn't form tubules, it just can't stick together enough. A typical finding is that the cells form what we'd call Indian files. These are long strings of single cells slicing between the rows of collagen. Of course, lobular carcinoma comes with its own in situ carcinoma, lobular carcinoma in situ, LCIS. This tends to be incidental, not usually seen with calcifications and not usually mass forming. It's more frequently bilateral than DCIS, and the cells in the lobular carcinoma in situ are identical to invasive lobular carcinoma, including the loss of the ECAD-herin gene. It's really hard to pick up on mammography because it doesn't form calcifications or a mass. So microscopically, as we can see here, we've got the discohesive cells with the round nuclei and small nuclei filling up these tiny acini. They're often quite a uniform set of cells and can have signet ring cells in them, like that other tumour that has lost ECAD-herin, the gastric signet ring cell carcinoma. How do we know whether a woman is going to do well or badly with breast cancer? How do we know whether or not she needs hormone receptor treatment or she needs Herceptin? We do this by looking at the histopathology of the breast excision. After we've decided what kind of tumour it is, we work on the stage of the tumour. So stage, we use the TNM staging system. The T is about how large the tumour in the breast is. The N is about the lymph node status. And the M is about whether or not metastases are present. So the outcome of a breast cancer is most influenced by the TNM stage. The grade of the breast cancer, and we grade them from 1 to 3, can also influence outcome, with grade 3 being worse and grade 1 being better. In addition, every breast cancer will be stained for estrogen and progesterone receptors, because if they're present, the woman can be treated with tamoxifen or aromatase inhibitors to switch off that estrogen or progesterone receptor. They act as growth drivers. So if we can switch off the growth of the cancer cells, well, then we can make the cancer go into remission. The last thing we test for is HER2 status, and we'll talk about that in a few slides' time. You've probably heard of HER2 and its drug Herceptin. HER2 stands for Human Epithelial Growth Factor Receptor Type 2, and Herceptin is a drug that can block this growth factor, turning off the growth of cancer cells that express it. This sounds good, right? There is a downside, however. And the downside is that HER2 positive tumours are bad. They are bad. They're the worst performing tumour of all the breast cancers. So, what Herceptin does, it's not really a miracle drug. What it does is it takes the breast cancer back up to ordinary prognosis. There's a problem with Herceptin. It can't get into the brain. And so newer drugs have been developed which can cross the blood-brain barrier and treat metastatic breast cancer in the brain. So finally, we're going to revise what we've learned. There are benign changes in the breast, fibrocystic change. They're common, they're hormone-driven, they can have calcifications in them, and they can form little lumps that fluctuate with the menstrual cycle. The commonest benign tumour is the fibroadenoma, the breast mouse. It's ovoid, slips between the fingers, occurs in women in their 30s. And then there's breast cancer, in situ and invasive types. We can look at various things that determine the prognosis, primarily the stage. And then there are markers that we can do that help with therapy, ER, PR, and HER2. By mastering reading breast cancer pathology reports, you can choose the right treatment for your patient, and you can be a pathology superhero.